Okay, so let me check. Okay, let me share the screen. I think it's almost 4 because I don't want to delay it. Let's get start on. Can you see the screen? Okay, just thumbs up. No voice from you guys? Are you guys are here? You can open your camera. I'll just start it in a while. Okay, so today our topic is on psoriasis. So have you all went through the case study in the e-learning? Okay. 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 So today we will discuss the sign and symptom of psoriasis. I'll just go through briefly, okay, a little of introduction on the sign and symptom, the management, okay, just a touch and touch over there, and then later we'll come up with the case study, okay. So at the end of this class today, discuss, you'll be able to discuss, you're able to explain, you're able to suggest and provide appropriate counseling, okay. Okay. So, psoriasis is something like a pruritus type of disease, which is itching. Okay, and it's a chronic disease. Okay, it affects most about 75% of patient present with psoriasis before the age of 40. Okay, so there is high chance of students. Okay, within in that age group, 20s, early 20s, late 20s, even teenagers. Okay, they're more prone to develop this psoriasis. So it's characterized by recurrent exacerbations and also remission of thickened erythromas and scaling plaques. Okay, I'll show you the photos later. Okay, so the clinical manifestation, as I mentioned just now, pruritus, okay, is noted in 20% of the patients. It's sometimes it could be asymptomatic. Okay, you know what is asymptomatic? You don't show any symptoms. Also, okay, there's a Auspitz sign, pinpoint bleeding when the scales are removed. Okay, that shows one of the clinical manifestation, which is a sign of that. And a Kobner phenomenon when new lesions appear at sites of the skin trauma. Okay, where where you have a scratch or cut, right? There's a new lesions appears there. So the etiology. So what is the cause? Mostly is number one is genetic factor. Okay, most patients have genetic factor of this having developing the psoriasis, and also exogenous trigger factors. Okay, climate, cold weather, yes, alcohol, infection, drugs. Okay, certain drugs. Okay, this is very important. Certain drugs can cause psoriasis, and stress, smoking, and trauma. Okay, all these are the trigger factors from external. So these are the drugs that I told you that reported to induce psoriasis. So you look at the example: antibiotic, amoxicillin, okay, ampicillin, anti-inflammatory drugs, anti-malarial. Okay, all these are the example that can induce psoriasis. It's not compulsory, but it could induce that. So the National Psoriasis Foundation has classified psoriasis based on the severity of the disease. Okay, like if you want to look into some disease, you want to see the severity of the disease, right? So for this psoriasis or any kind of skin disorders, usually we look into the body surface area, which we call as BSA. So usually up to 5% of body surface area affected, it usually is considered as mild, and usually you can use topical treatment for that. If it's more than 5% body surface area, then you need to use higher concentrated medications, for example systematic or phototherapy. Okay, so how to look into the body surface area, we will learn later. Okay, so you have to is the important thing is body surface area. Okay, so this is just to refresh you what are the type of psoriasis available. Okay, the most common one is the plaque type psoriasis. So this is the one that affects 80 to 90% of the patients. Okay, usually it'll be like, there's a well defined of red patches, and it looks a bit dry. Okay, and it's always can appear in your scalp. Okay, your head, yeah, scalp, elbows, knee, palm, soles. Okay, but usually does not involve the face. Scalp is common. Okay, so these are the common. The plaque type psoriasis is the most common one. Even in Malaysia, Malaysians young adults affects the Malaysian young adults. Then we have the inverse psoriasis. These always appear in the folds, like for example in your armpits, all right, under the buttocks, near the genitals. It usually have a folds. Okay, it doesn't appear in your own normal open area, surface area. It opens in your, all the what you call in Malay like a lipatan lah. Okay, in the celah tangan or kaki. Okay, so this is what is inverse psoriasis. So you see the photo, yes, it appears here, and it got can produce the yeast overgrowth, also common in skin folds, may trigger the skin lesion. So just now this is not really much, but the earlier one which we talk on the plaque type, this is common. Then we have this. This is one of the severe type of psoriasis. This is erythrodermic psoriasis. Okay, okay. You see this can appear in the whole body. Okay, and it involves more than 90% of the BSA. Okay, so that when you see that more than 90%, you can know already how severe is that psoriasis. Okay, usually it will be itches and you feel like a burn. Okay, and this is really terrible conditions. Okay, and you should it's common to have fever or malaise. Then we have guttate psoriasis. Okay, this is a small scaly erythema spots. Okay, and usually it's happen in the trunk. Okay, trunk parts and limbs, and often triggered by a preceding upper respiratory infection, even though it's not really common. And then we have pustular psoriasis. This is a pus-filled blisters. Okay, it is uncommon form. Okay, usually occurs in palms or soles. Okay, okay, this is psoriasis arthritis. This is chronic inflammatory arthritis, and this one usually happens in 5 to 10% of people who have psoriasis. Okay, and unfortunately, it is more common in men. Okay, when the psoriasis is generalized. Okay, so this is also. Okay, we go for the next, nail psoriasis. Okay, just now was psoriatic so arthritis. Okay, there's this nail psoriasis present in up to 80% of the patient with psoriatic arthritis. Okay, so you look at the picture here. So it looks like this. This is the nail psoriasis. Okay, it looks like yellowing discoloration. Your scale is like coming out. So all this is nail psoriasis. So, what are the impacts of this psoriasis to a person? So, of course, when you have such things, all right, you will have a reduced quality of life. When the patient has this, they feel shy to go out. All this. That's I said reduced quality of life. They do not involve in any activities. So that is related to impairment of social, psychological, and physical functioning. So, for us as pharmacists, what is our goal of therapy for patient who comes to with psoriasis? We want to achieve complete clearing of psoriatic lesion. All right. And the treatment goals for severe psoriasis include safe and effective resolution of the disease, okay, and maintenance, okay, to avoid any remission. Remission is you to get it back. Okay, so it's easy to get back. Okay, that's it relapse, huh? The disease can relapse to yourself, so you have to prevent, treat, and also prevent from the relapse. Okay, so far understand, huh? So usually treatment, I'm just going brief before we go for case study. So these are the topicals available. Okay, we have emollients, we have anti-proliferative. Okay, example, it's calcipotriol, Holta. Okay, anti-inflammatory topical means it's like you can it's like cream and lotion and all these things. Okay, so for anti-inflammatory you have hydrocortisone, betamethasone, okay, all these steroid types. And then we have descaling agent, salicylic acid. Okay, all this example which I put it here is available in our hospitals. Okay, and we have also another, okay, just now was topical treatment. When I told you that when the body surface area of the patient affected is less than 5%, you can just use topical treatment. Okay, that's why when your patient who have mild psoriasis, they usually don't go to hospital. They usually go to the community pharmacy. Okay, they go to the Georgetown pharmacy. They go to what else? Any pharmacy, Mega Life pharmacy, and then they tell the pharmacy that they're having psoriasis. They show, and then they buy from there because you can get it. You can get all the tropical, all these available in the retail pharmacy, and this not doesn't usually not much needed prescription. But if let's say the patient's body's BSA is more than 5%, like for example, if it involve about 30-40%, there's a chance to use other type of treatment, phototherapy and systemic therapy. Okay, so this is usually done in hospital. So you have UVB, okay, all this UVA, UVB light. Phototherapy usually done 2 to 3 sessions per week. Okay, for moderate to severe plaque psoriasis. Okay, other type of psoriasis also can, but I'm just concentrating on the what is the common psoriasis in Malaysia. But phototherapy, there's a risk of burn if used excessively. So that's why the doctor usually order just once, like for example in a week, maybe 2 sessions or once, okay, and then they have it for a few short duration of time. And this is a systemic therapy. Okay, so this is commonly available in our hospital: methotrexate, cyclosporine, acitresin. Okay, so this is also used for moderate to severe therapy of to treat psoriasis. Okay, so methotrexate is available in oral doses, and cyclosporine and acitresin. So usually this is methotrexate is given weekly. Okay, so this is available one. And then nowadays we have the newer systemic treatment, which is called BRM, biologic response modifier. Okay, so this is for example etanercept, secukinumab. Okay, this the one that I give example is available in the hospital. All right, especially the hospital which has a dermatology clinic, we do have all this kind of medications. So all these the one I told you is topical, UV, systemic therapy. Okay, all this depends on the BSA of the patient presenting. Okay, for moderate for the mild, you can just use topical, that's fine. But if moderate to severe, the doctor might want to use a combination. Maybe they want to use UV plus topical plus systemic. It's up to the doctor. It's I mean not up to the doctor. Yeah, it's up to the doctor and also up to the condition of the patients. Or maybe the doctor want to use systemic and also topical. Yeah, could be. Okay. Okay. So these are the treatment algorithm. If mild to moderate, usually use topical agent. If let's say if ineffective, okay, if it's mild, usually it'll be effective. But if it's moderate, if it's still ineffective, you can use topical agents and phototherapy. It's up to up to the conditions. And if it's not adequate, still the psoriasis is getting worse, then you can start topical agent and systemic agent. Okay, this systemic agent, usually doctors won't start very early, because methotrexate, all this, the drug has a lot of side effects, so usually we consider it as the um if it's the condition goes severe, okay, moderate to severe. And sometimes when, if you already, let's say it's your psoriasis is moderate, the patient comes to moderate, okay, when already we treat with topical agent and phototherapy, once the psoriasis goes mild, and from moderate it goes to mild, I mean it is helping them up, then we taper down, so we just go for topical agents. So this is more treatment algorithm for moderate to severe psoriasis. Okay, so this you can use as systemic agents, topical agent, or phototherapy, and also you can consider BRM. Okay, so it depends on the conditions. If still ineffective, then you use more potent systemic agent, or two systemic agents in rotation with topical agent. Okay, or if still not, then you use the BRM with other agents. You can use topical agent at any stage. Shouldn't be a problem. Okay, so Ken, so far so good. Can anyone answer me so that I know like anyone
Yes,
is listening?
doctor.
Ah, good,
Yes,
good, good.
doctor.
Okay. So now have you all went for the look into the case study?
Yes, doctor.
Okay. So do you all want to answer it here, or you want me to divide you into group and then you give me the answers there? Which one you all prefer?
I think can answer here like immediately.
Pardon?
I think can answer now. No need to break up session.
Okay, so that means you're all ready with these answers, huh? Okay, all right. Okay, then I'll randomly just choose people, or you can volunteer. Okay, I prefer you all volunteer lah rather than I picking up. Okay, let's go for this case study. Mr. William. Okay, maybe someone can read. Just now, who is it? Mama Arif, is it? Can you read it for me? This case study.
Okay. Alright. So Mr. William is a 35-year-old gentleman, a teacher who has a history of psoriasis unlike pain. Presented with worsening plaque of psoriasis with thick, scaly lesion on the elbows, knees, and scalp over the past 1 week. For past medical history, he has chronic plaque psoriasis, which she diagnosed over 10 years ago, hypertension, and also for social history, he is an occasion of alcohol consumption and a smoker with 8 cigarettes per day. For the vital sign, his BP is 139 over 86, pulse rate 88, and also for body temperature is 37 degrees Celsius. For impression of the skin, confluent plaque psoriasis with extensive abdomen, arms, legs, back, and scalp lesion. Pink fracture lesion on elbow, knees, palms, and soles. Lesion red to violet in color, with sharply demarcated borders except where confluent, and are loosely covered with silvery white scales. There are no pustule or vesicles. There are no acceleration on the trunk and extremities consistent with scratching. For current medication, he has temesartan 40 mg OD, hydrocortisone 1% cream PRN, Equus cream TDS, celecoxib OD for his knee pain.
Okay, thank you, Arif. So okay, so you went through this case study. Is also in the e-learning. Okay, so okay, now we go for the question one by one, and we discuss. Okay, you might have other answers, so we can discuss. So I want some volunteers, since you already have your answers, you already went through. So please, just raise your hand, or I mean you can, you can just take out a mic and just answer the question. So we start with the simple one. So it's better for you to start with the simple one. Number one, yeah. What are the okay? What are the clinical manifestation consistent with psoriasis does this patient demonstrate. Yeah, this patient is William. This patient demonstrate. So anybody? Can unmute yourself and just talk. There's no wrong, no right.
Hi, doctor. I would like to try.
Hi, what's your name?
My name is Nur Sirajuddin.
Okay, good.
So for the first one, I think the thick crusted lesion on elbow, knees, palm, and also sole.
Okay,
And then red to violet plaque. And
okay,
also excoriation due to scratching, maybe. And it affect large area of the body of this patient, of
okay.
Mr. William.
So mostly you're talking about the impression of skin, right?
Yes.
Okay. So any more other question? Sorry, any more other answers?
I think that's the answer for the
Sir.
first question.
Okay, this is Sirajuddin. Okay, thank you. Anybody else want to try? Anybody want to ask? Want to let you know your opinion? Nur Aida, Adnan.
Yes, doctor.
Okay, so what would be your answer? Or Mr. William, what do you think his clinical manifestation?
Uh, uh, his scalp, doctor. His scaly lesions and
Okay,
scalp.
okay, scaly. Okay, and then so this is plaque psoriasis, right? Nur Aida, are you still there?
Yes, doctor.
So you understand what type of psoriasis is this?
Yes, chronic plaque.
Okay, plaque psoriasis. Okay, fine. Okay, so let's see the answer. Okay, so the answer is worsening plaque psoriasis. Okay, so it's a type of psoriasis, it's plaque psoriasis. Already given the answer in the case study with thick scaly lesion on the elbows, knees, and scalp. Okay, all right, good. So we go for number 2. Okay, what are the risk factors predisposed to psoriasis for this patient? So what are the risk factors that he has that you think has predisposed it to psoriasis? So yeah, again, anyone?
Doctor can answer.
Who is this?
Arif again.
Oh, okay.
Uh,
Okay, good, Arif,
it's
yes.
okay. Okay. For the researcher,
Mm-hmm.
is for the first one, alcohol consumption. He is a occasional alcohol drinker. The
Okay.
second one is smoking, and the third one, is it, because he already been diagnosed with plaque psoriasis for 10 years ago.
Okay.
Right. So that's all for me.
Okay, thank you. Any other answers? Maisie?
Doctor, I think
Yes.
maybe the patient having anxiety or psychological stress
Okay. Why you think that?
because he is a teacher.
Okay. Some more? That's all, huh? Okay.
Maybe he
Uh,
also having cuts or burns on the skin. But we don't know in this case. But can be a risk factor.
okay. So this is your risk factor, eh? Okay, let's go for the answers. Okay. Nobody told this. Drug induced. That's why, during the first time I was stressing this. Drug induced psoriasis also can, because the patient was taking, do you remember he's taking for his knee pain? Let me show the case study. That's why I was showing this celecoxib OD for his knee pain. So celecoxib, Celebrex, is a NSAID. So it can induce because he's already have psoriasis for the past 10 years. So that was his past history. So it could smoking, alcohol consumption, and yeah, actually in general I would like to add in obesity. You can also contribute to that. Okay, but the most common is the most important is, remember, this drug induced smoking, alcohol consumption.
Doctor,
Yeah.
can age also be considered as a risk factor or
Age, okay, actually is more commonly less than 40, but you can get it at any age. So there's not really a risk factor with the age. But you can say it's not risk factor, but it's one of the thing that you see in a younger adults. So you don't consider as a risk factor actually.
all right, thank you, doctor.
Okay. Any more question? Okay, so if you have any question, you just stop me and ask. Okay, I'm okay with that. So what is the goal therapy? Okay, this is the same thing. Okay, I just copy paste of my previous slide. Okay, so this is the one that like one, how to tell, is like one paragraph saying what is supposed to be done, your goal therapy, but you have specified. Okay, so okay, what is this other goal therapy, specific goal therapy? Okay, the next slide has the answers already, so I need to just stick here first. So yeah, anyone, any specific goal therapy for this patient? Like the general that we are in the slide that you are seeing now, it's the complete clearing of psoriatic. Okay, include safe and effective resolution and long-term maintenance, which you prevent and treat. So what is a specific goal therapy? Anyone?
Doctor, can we please stop the aggravating factor, which is the drug?
Okay, good. Who's that? What's your name?
Christina.
Okay, all right. So apart from that,
Doctor, can we mention about to improve quality of life of the patient?
to improve the quality of life of the patient, yes, but you get to improve the quality of life patient by how? Okay, patient has psoriasis. How do you what is your goal? Okay, your end product is quality of life, but now what you do to improve the quality of life?
By alleviating the symptoms such as pruritus and
Okay,
minimize the signs such as the plaque and the scales.
okay, so you want to reduce the symptoms, right? So that your
Yep.
end your end is to increase the quality of life, right?
Yes, doctor.
Okay, any other thing? Okay, Ong Chin Wen. This is coming to my screen now. That's why. Ong Chin Wen.
Yes, doctor.
So anything that you want to add in? What is the specific one?
To reduce the lesion size and also prevent the recurrence of the psoriasis.
Okay. Okay. So, but it's always already, I think, said before. So you have any other things?
Eh,
Okay. Let me go another person. Wanisa.
Yes, doctor.
Yeah, what is your specific? Okay, now you are in the pharmacy. You are the community pharmacist, and then patient comes with you. This William comes to you. He doesn't trust others. He comes to you now. So, what is your goal therapy for this patient? So, how do you explain to the patient what do you want to do? I mean, you can't be you won't be like telling this to the patient, right? So, what is your short term goal therapy or long term goal therapy?
To minimize the flare frequency
Mhm.
and also to also avoid the long-term adverse effect of the treatment.
Okay, what can you give me example or what adverse effect, long-term adverse effect? Any of the medication that you can tell me? Okay, when you have this psoriasis, okay, just now I mentioned to you, the impact is mostly on quality of life and also emotionally. All right. So when I say that's emotionally, okay, so what is your goal therapy for that?
Also, maybe his skin appearances.
Okay, so you want to build his confidence.
Yes, by reducing the scaling.
Okay. Okay, let's go to the answers. Okay, so yes, minimum the sign and symptoms. Okay, correct. Reduce the frequency of flare-ups. Okay, this I think was not mentioned. I think okay, you need to reduce the frequency because sometimes psoriasis it can flare up. Okay, sometimes it depends the weather triggers or anything. It can flare up. So you want to reduce the frequency. So you need to explain to the patient to avoid the the what you call the etiology that can cause, for example, the accident that I all this that you need your stress level and says okay. So all this is your specific goals. Then you have like minimizing the non-specific triggers. Okay, maybe you have like sunburn, chemical irritants, or environment, workplace factors. Okay, and provide guidance or counseling. Okay, usually remember psoriasis, all these skin type of disorders, usually counseling is always needed. Okay, all right, and then providing cost-effective therapy and maintaining or improving our quality of life. Yes, that is what was mentioned earlier. Okay, okay, okay. Okay, this is a bit challenging. What feasible pharmacotherapeutic alternatives are available? Okay, or would you suggest for controlling the patient's disease and its related symptom at this point? So, who want to try? So, you have to identify whether the patient has less than 5% of BSA or higher than 5%. And then, what do you think that you would suggest? Who wants to go?
Hi, doctor. Can we suggest phototherapy because this patient has the extensive psoriasis at abdomen, arm, legs, back, and scalp, which is considered more than 5%.
Okay, okay, good. Actually, it's more than 5%. Yes, because as you say, when you look into the case study, you have to look where is all these, where he has these problems. The whole, almost nearly the whole body. Okay, good. And you say phototherapy. Okay, would you like to start phototherapy alone, or do you have a combination?
I will start phototherapy and the topical
Mhm.
therapy and add on moisturizer for this patient.
Okay, so meaning topical treatment. Okay, that means moisturizing like aqueous cream. Okay, you want to add steroid cream, aqueous cream, and you want to add this UV, is it?
Yeah,
Phototherapy.
yeah.
Okay, okay, okay. How about others? This is I mean, there's a lot of answers. There's no one correct answer. So what? How about others?
Doctor,
Yeah.
can we add other topical agents such as calcipotriol into the regimen?
Okay.
For example, calcipotriol 0.005 cream
Uh-huh.
to be applied at the affected area 2 times daily.
Okay. So you mean you just adding the topical only?
Yes.
Okay, you want to add topical only. Okay. But okay, you see this study. Okay, it's good that you understand, but the patients already have past medical history of chronic plaque psoriasis, which means he has diagnosed 10 years ago. So now he's coming with the flare up. So but this case study did not inform us whether the patient had any relapse before. Like he's coming after 10 years saying that he has psoriasis now. So whether did he have anything in between these 10 years where when he was diagnosed? How was his severity? It was not mentioned. So I assume that this patient memang ada chronic sikit. So and it's also involved more than 5% of BSA. So topical alone might not be helpful unless unless the patient says that when he applies at home, usually all this this having already diagnosed 10 years ago, they have chronic psoriasis, they have they usually buy their own self the topical treatment. So from pharmacy, they try to apply. When they fail, then only they come because they already have experience. So in that case, probably topical would not alone would not might be enough. Okay, so you might want to add in systemic therapy. Okay, it's good. Anybody else?
Doctor, can we give this patient methotrexate?
Methotrexate. Okay, what is the dose that you would suggest for this patient? So you want to give methotrexate only or how?
Together with topical corticosteroid. Very can give potent corticosteroid like betamethasone
Okay,
and methotrexate.
methotrexate. What's the dose that you want to give
The dose for methotrexate is can start with a test dose of 5 to 7.5 mg per week.
per week?
Per week, and a folic acid supplementation 5 mg per day.
Okay. Why you want to give folic acid?
To reduce the hepatic adverse effects of methotrexate.
Okay, okay, all right. And then could you take okay folic acid is taken how frequent? Okay, this is what I'm not asking. Don't worry. This is for us to discuss. Okay, in practice. Okay, when I was working in hospital, usually methotrexate for all the skin type. Usually they give once a week, and then even in for orthopedic. Okay, for if you have any arthritis, also you have given methotrexate. Yes, Okay, for skin, folic acid, usually for when you add methotrexate, yes, you're given folic acid. But what I've seen in practice, when you have once a week, folic acid also was given once a week. Okay, but you don't take on the same day. For example, when you ask the patient, take methotrexate once a week. Okay, you let them know you take every Wednesday. Then this folic acid you take either Tuesday, Thursday, Friday, any days, not the same day. Okay, so this is what happens in hospitals lah. Okay, so once a week. But I've seen doctors who also ordered folic acid for daily, but on the day when they are taking once a week dose of methotrexate, you don't take the folic acid. So it depends on the conditions. Okay.
Okay, doctor.
Okay. Okay, so any other? What's the time now? Okay, 4:40. Any other things? Let me go to the answer. Okay, so just now, okay, we already know that it is more than 5%. Okay, if moderate is 5 to 10%. Severe is more than 10% lah. Okay, so how to determine the percentage? Okay, if only palm size involved, then it's about 1%. If only head and neck, then it's 10%. If both upper limbs, 20%. Trunk involvement, front and neck is 30%. Both lower limb, 40%. So this is of course obviously is severe condition. Okay. Okay, so topical agents is given to mild to moderate. So you have emollients, you have coal tar, okay, and then do you have the one that available easily calcipotriene, okay. This all is the topical agents, okay. Calcipotriene usually you'll see in hospital that have dermatology clinic, okay. So some hospital does not have dermatology clinics. So you only see where, for example, hospital Al-Star, Sultanah Bahia, they do have dermatology clinic, and they usually is very common to have this medication prescribed. Okay, Colta, but Colta now is getting less popular. Okay, because it's quite has a strong smell which is unpleasant. Okay, a little you rasa busuk a bit lah, I mean the what do you call the smell. So but it still be using also as well, and usually it's being prepared in the hospital. Okay, so and then all the emollients, okay, which only provide minimal relief alone. Okay, so you can look into what is the advantage and disadvantage. Okay, calcipotriene, it is effective, it's slower onset, but usually it is okay, it is quite effective for psoriasis. So usually dermatology clinic, okay, for psoriasis they usually give this cream. Okay. This is systemic agents, which is severe. You have UVA, okay, and then we have ectretine. Okay, this is quite not as effective, but it's still given. Okay, usually it's given with phototherapy. Okay, and it's less hepatotoxic than methotrexate. So that's why it's based on the condition. If the patient has liver liver profile is not good, not safe, then you don't give methotrexate to patient, you give ectretine. Okay, all right, then but of course ectretine, it is teratogenic. So usually for ladies contraception is required. Okay. Okay, and usually you can give for patient with a slight liver changes, but not with total liver dysfunction. Okay, then sorry, cyclosporine. Okay. Okay, all right, okay. Then we have this all these immunomodulators, that which I mentioned to you, the biological modify response, all these are the immunomodulators. These are the newer type, and this is very expensive, and this is parental therapy. Okay, which is you need some injections types. Okay, so it's only available with the hospitals which have the dermatology clinic. Okay, so let's go. So just now, okay, systemic therapy, Okay, just now your friend was mentioning that yes, methotrexate weekly dosing. Of course, you can add on with folic acid. Okay, but you need to monitor the liver function. Okay, you need to monitor that. Okay, but caution with alcohol. For topical, you might want to give high potency corticosteroid, clobetasol. Okay, propionate 0.05%. Okay, for thick plaques on elbows, knee, palms, and so. And then you might have to you also might want to consider calcipotriol and betamethasone or colta. Okay, this is more for scalp, scalp or salicylic acid basic shampoo. It's more for your scalp, where you have your scalp psoriasis. And have a moisturizer. Moisturizer, you can have like aqueous cream to restore the skin barrier. So this is one of the suggestion. You can use ectretine 25 milligram OD plus phototherapy plus any of the moisturizer. So this is just an example. So a suggestion. Okay. Okay, so this is Malaysian CPG. Unfortunately, our CPG this is the, I think the one that I got is 2013 only. So you have mild, moderate, and severe. Okay, so if the severe case, you start straight with phototherapy. If not available, okay, even for example, if that hospital does not have phototherapy facilities, then straight go to systemic therapy, that is methotrexate, ectretine, okay, and cyclosporine. Usually methotrexate is the first line. Okay, or you can't I mean, if you can't able to use that, then you use the newer agents, yeah, the biological agents. So you use the newer agents. Okay, so this for the severe. For mild, you usually start with topical alone. Okay, all right. Okay, let's go for number 5. We got until number 7. So number 5, what non-pharmacologic alternatives are available for managing the patient's psoriasis and related symptoms? So who want to answer? Shafika? Oh, anybody? Oh yeah, anybody volunteered? Can go ahead.
Okay, doctor, I will answer.
Okay.
I will suggest the patient to apply moisturizer whenever needed to maintain his skin moisture, to reduce the skin shedding and control the scaling and reduce the pruritus. And need to continue with all the topical treatment given to this patient. And another alternative is to use sunscreen when he go out for outdoor activities, prefer high
Okay.
SPF to prevent sunburn, and always clean his skin with the lukewarm water and preferably with lipid-free and fragrance-free cleansers, and ask him to quit smoking and reduce alcohol consumption.
Anyone want to add some more? Just now I called one name. What's the name? Shafika. Yes, I remember. Shafika?
I think maybe I can add about diet.
Mm-hmm.
Diet.
What type of diet?
Can consider anti-inflammatory diet, like take any food that rich in omega, vegetables.
Mm-mm. Okay. Is food dietary is always any cause for the psoriasis?
No.
Okay. So why do you want to put this non-pharmacology alternative?
Mm, I think most of the non-pharmacological have mentioned by
Okay, can you just mention one of the
about
things that she mentioned?
use the moisturizer and then wear sunscreen to prevent UV exposure,
Okay.
and also avoid using like fragrance,
Mm-hmm.
and then also he can also manage about his smoking cessation,
Mm-hmm.
and also about alcohol intake.
Okay. Okay. Good. So the rest of you heard what Shafika mentioned, right? Shafika and Eng Meizi, right? So this is what this is a discussion. We want to discuss what's the answer. There's no right and wrong, but I mean, yes, smoking cessation, limit alcohol intake, stress management, okay, and patient education. Okay, this is always you can mention patient education. Okay. Okay, and also I just want to add, yes, sunscreen already mentioned. Oatmeal baths can further reduce pruritus. Okay, you can also suggest it oatmeal baths. Okay, and also non-medicated emollients. Okay, all this moisturizer that you use, you can use the non-medicated. Okay, the normal, the lotion, which is reduce your dryness. All this you can use, and minimize irritation to the skin. Avoid harsh soaps or detergents. Okay, usually what we recommend for patients, usually we recommend all these baby shampoos, baby soaps like Johnson, Anakku, or means certain something like this type of brand where you use for babies. Okay, that is supposed to be the pH should be neutral. Okay. Okay, good. Okay, number 6. How should you monitor your recommended therapy for efficacy and adverse effect? So how do you monitor? Nelson? Nelson Kwek, is it? Nelson. Okay, so how do you monitor for this patient recommended therapy? How do you monitor? That all is suggested, right? The systemic therapy. So how do you monitor? And what profile that you monitor? Mm, okay, okay. So okay, okay. Okay, the most important thing is that methotrexate, echinacea, all this, is hepatotoxicity, right? So you should do this liver function test, okay? Then because this question is monitor your recommended therapy for efficacy. That means what we suggested. What do you want to monitor after you prescribe this medication? What do you want to monitor? It's okay. Okay, thank you. So okay, so like just now as mentioned, so you need to outline this, like MTX is methotrexate, so liver function test, renal function, okay, and then folic acid supplementation. So all this is a monitoring part, liver, renal, okay, and then blood test as was mentioned. Okay, and then the echinacea, okay, you should be looking into the, just now I told you, for the contraception and everything. So you need to look into whether the for women of childbearing age, okay, should not be used lah, unless they're using the contraceptive method. Okay, all right. And then topical, avoid duration limits for high potency steroid. Usually very high potency steroid, we don't ask them to use in a which advise patient to apply on the face. Okay. For phototherapy, okay, just now was systemic therapy and topical. For phototherapy, you need to look into eye protection. So you need to monitor your eye protection. Okay, or for all these UV light, so that's why you need to monitor the eye protection. Okay, let's go to the last question. Okay, and this is the very important question because usually when psoriasis cases, the doctor will see and they will come to collect your medication and you have to provide the counseling points. So this is actually the main point, main important things lah. Provide counseling points to Mr. William. So okay, anybody volunteer? You volunteer, we can finish it up. Or you want me to call your names? You all like me to call your names, huh? Nur Hidayah? Nur Hidayah? We cannot hear Nur Hidayah. Or anybody want to help? I think she's having problem with her mic. Anybody want to help? Okay, let's go through first. Provide counseling points. Okay. So Mr. William is having psoriasis. He's a chronic psoriasis before. So the same thing, non-pharmacological. So it's quite simple. Excess alcohol, it can damage your liver, especially when on methotrexate. So if the patient is on methotrexate, you need to advise all this. Certain painkillers like NSAID, okay, unless approved by your doctor, it could induce your, your psoriasis. So for example, in this case, patient was using Celebrex. Use high potency corticosteroid only on thick plaques. Okay, so when you have this medication, usually in the envelope of the patient, you always to write for them. Okay, apply in sapu dekat tempat tebal. So this is high potency corticosteroid. Okay, so usually that's what we do in the hospital. Okay, in the envelope we write there dekat kawasan tebal. That means lah, apply on the thick plaques. Okay, limit alcohol, just now the same thing, and also engage in stress relieving activities. So these are the counseling points, and if they're using like methotrexate once a week, you need to counsel them. Okay, avoid hot water baths. Okay, use lukewarm water and gentle soap, as I mentioned just now. Apply moisturizer immediately after bathing to lock in moisture. Okay, and also you can ask them if they are in the air conditioned room quite long, ask them to apply moisturizer. Okay, it's good. Okay, this is not for only for people with psoriasis, even for us. If you are you are sleeping in aircon, you are using aircon a lot, please use moisturizer. Okay, to prevent the skin from drying. And then emotional support. Okay, you give them some emotional support, like tell them that you this can be treated. Okay, and then give them some confidence. Okay, so okay, any question? Anybody want to ask any question?
Doctor, can I clarify? Can we use phototherapy and systemic therapy?
Can
Oh, okay.
Because
Thank you.
phototherapy you only use for short term, 2 times a week, and you give a short time period. Methotrexate can go up to, it depends, like you have to monitor your liver and everything. So you can go up to 2 months, can. But phototherapy is shorter. Anything else you want to ask? I think for this semester this would be my last one. I think I have no more other topics to lecture you. So anything else you want to ask? Or you already, all of you all went to your hometown already? Okay, so the next give you the attendance. Okay, no problem, Hidayah. I know your mic was not working. I know you were trying, so I saw that. It's okay, no problem. Okay, so before I end, wait, let me stop this first. Okay, so I think that's the end. It's already 5. So before we end, I just want to ask you, because I know we have like very short time to discuss cases. So if you guys want, you want some extra tutorials for me to, prepare you a case, or you want to discuss any case that you, Clark, I'm open for it. Okay, you just let your class rep know. Okay, and then we can arrange a time. We can have it online if you want to, or you want to have face to face, up to you. But if you have it online, because it doesn't disrupt your timetable, your classes, and okay, so you can have it anytime evening, or you want to have it at night, I'm okay with that. We can do it online. So it's not compulsory. Those who only want to join, you can join. Okay. Okay, so anything else? I saw somebody was messaging. Managed to submit because my phone lagging. Okay, it's in the e-learning. You those who cannot have not managed to do that, you can just go to the e-learning. Okay. So in case you want anything to, to discuss, okay, just let me know. We can arrange it. Okay. Okay. So have a nice weekend. Thank you. Bye.
Thank you, Doctor.